was very easy. You can just see the fluoro, save of getting into the, this is the other one, okay. The right coronary artery was okay. Non-obstructive remained non-obstructive. So we're trying to engage with the guide. And we do have our app where we are showing how to engage actually in the Evolute and then the Sapien, but Navitor, recently approved. So if you see here, get into the diamond very easily. Then we have to manipulate a little bit and able to engage into the coronary artery. So non-obstructive circumflex.
No, Ramus we call 60%, remain about 60% there now also.
Okay, if you can go here. So this was a dry cine showing tram track calcium in the LAD and the diagonal. And here we are. So about 90-95% diagonal. At the level of the first septal, you can see like a filling defect. We know this has been there even before. Could be a calcific nodule, could be just an eccentric plaque, but then definitely you have moderate disease in the LAD.
And the diagonal has clearly progressed. LAD also about the same, it's about 70%, but diagonal definitely became 90%, and I'm sure that caused the troponin positive progression. And then the calcific, at the level of the septal, if we can continue to play, well, and I think let's guess it because we are going to show that with the IVUS, let's take the vote from the panelists at the level of the septal. Is it eccentric plaque, calcific nodule, or thrombus? Something is there or nothing. I mean, clearly something is there. The question is what it is. And that's, as you can see, the discussion point while we have taken, Anu has directly wired the rotor wire and we'll be doing this IVUS on the rotor wire.
Yeah, no, Samin, I think that's a great point. There's a filling defect, all these differentials that you have, like Dr. Cox, what do you think?
Okay, we do IVUS.
I think you're doing the right thing. Let's get an IVUS figured out because we can think and think and think. We got an image.
Good. And let's look at
now. Yeah, IVUS catheter is not moving, so it could be some
very tight lesion in the LAD.
Okay, Kiski, can you go live?
Okay.
Let's show the IVUS in the side.
Yeah, it's a 360 calcium. Okay, I start fullback. It's a 4 millimeter per second. Quick fullback. Yeah, 360 calcium. Come to the proximal LAD. Yeah, so tight. Yeah, isofluturidine calcium. It's a nodule.
And this is the new fast-moving IVUS. Yep.
Yep.
So show us that nodule versus what it is, and then we'll discuss.
Yep. So I'll show you from the proximal to go to the distal. Now this is the left main bifurcation. It's a prox LAD. Okay, this is a big branch, D1. And now here, very like overselective, like eccentric, like a calcium protruding inside.
So this will call it the severe calcium and nodule?
Yeah, this is a nodule. Yeah.
And also substantial calcium behind the proximal and the distal. It's not a thrombus, it's a calcified nodule.
Yeah, and it is a healed calcified nodule rather than looking like an eruptive nodule. So that's the difference. So, I mean, this is calcium treatment 101 right here.
Yeah.
You have to understand what kind of calcium you have, and if you can image pre, it is more beneficial than anything you do. So this is great, guys. I think understanding the type of calcium and how do we treat the calcium is very, very important, really.
And the biggest question will come, what everybody thinks about the diagonal. Look at the very big diagonal. So go back to angiogram now. I think this is okay now. We'll understood. We'll come back, Kiski.
Yeah. Wait 1 second. At the level of the dia, Kiski, give us the CSA of the MSA of the LAD. It's 360 calcium at the level of the dia. Go down. Oh, no, we didn't reach there.
You mean
no, we did not cross. We were just a little short.
I think this is a D2. So yeah, after that, yeah.
What's the cross-sectional area there? Yes, area.
1 second, please. I mean, the AI doesn't work well because of the artifact. But it looks like manually, it's like area is like a 3.3 3-0.
Okay,
After the D2, cross section is 3-0.
yeah. So
And
that need to
diagonal
be
is gonna
taken
be
care.
hard to see.
Yeah.
It's gonna be hard to see with calcium, and you get attenuation artifacts. So sometimes side branches are difficult to see
Yep.
when you have attenuation on the same side as the calcium that you have. But you can see, and then whenever you do imaging here you have to go into the branch to really assess the true ostium. You may sometimes overestimate that area when you pull on IVUS.
Right.
And OCT can do 3D reconstruction, and you can actually just do the main branch and look at the diagonal per se. But with IVUS, you usually have to go
Go back
to
to
that
angio. You can go back to
cross.
angio.
Yep.
And,
One cross. Very good point. Right.
At the level of the nodule, get me the diameter.
Sure. The
We can show the hemodynamic on one side, please, on the screen.
yeah, MLD is like 1.0, very obstructive.
1.0.
No, not that one. Get the whole thing. Yes. Okay. So we have a 1.75 bar. That was our visual estimate. Probably will be the right choice at that level of the nodule.
Anu, can you go over your rationale of choosing what form of atherectomy and shockwave CSI versus rotational atherectomy after looking at this IVUS?
Yeah, that's an excellent point. Here for the, if you see, now if somebody says I want to do orbital atherectomy, not a bad choice. You can also do orbital atherectomy here and go back to the level of that nodule.
Yeah, this is exactly the nodule part.
Okay, so the nodule, you see there is a lot of calcium at the level of the nodule, but the wall opposite to that does not have a lot of calcium.
True.
Yeah, so you go a little further down. So that is one thing favoring rotational atherectomy come by consider to orbital. But like here, you have almost I would say 3 quadrant to 4 quadrant.
Yep.
So this area would do very well with orbital atherectomy. I'm a big believer that if you have to do orbital atherectomy, 3+ quadrant, you need a calcium of 3+ quadrant. So I think at the level of the nodule, though data will say probably orbital atherectomy is better, and that's exactly the reason I asked him the diameter, which is about 1 millimeter. So I think 1.75 bar should shave off that calcific nodule at that level.
And
How
show
about,
the
how about lithotripsy?
won't go. Remember,
Won't go.
right
I
now
think-
will not go. Remember, did not go through and through. We'll show the angiogram now. So no, we'll use a lithotripsy, but as an adjunct. Play it again. So now question is to the panels. LED understood. We do. It's a run of the mill case. Play. Guys, pay attention or sleeping. Good. Okay. So. Okay. Pre. Yeah. Good. So see that now. No.
Let me do it. Let me do it.
Yeah, good.
Okay. Yes.
Sorry. Yeah. Look at the calcium even before the dye. To the previous one. Look at how dense calcium in the diagonal is. The question will come. LED we understood. Orbital versus rota both are equal. Orbital might have little advantage here because of the large calcific nodule. But since the area other side is not 3/4 calcium at the level of nodule, what our experience has been, what Anu mentioned, that orbital will cause a lot of deep cuts.
Deep cuts.
And therefore, so I think orbital OA, RA probably equal. Maybe orbital has slight, RA has a little advantage. But look at the calcific of the diagonal. Such a tight lesion at the ostium, that's where the question will come, that do we have to do the atherectomy rotablation of the diagonal, and which I say in this day and age, since where we have trouble with the rotablation in the ostial diagonals or basically diagonals. So I say that almost is like class 3. That doing the atherectomy of the diagonal at this day and age when IVL is available. So that is what we are trying to show here, that maybe do a little balloon of the ostial and then deliver the IVL. If we still cannot deliver, then we have to do a rotation atherectomy of the diagonal also. And I'll really love to see the everybody's opinion on that statement, that what else can we do in this very calcific diagonal.
Yeah, I mean, that's an amazing point, really, is because of the wire bias and the angle that you do. You gutter, you cause dissections, you can cause perforations. And here, the rationale, what Anu was telling us is if you look at this, such long lesion, IVUS would not cross.
Yeah.
So I think starting with lithotripsy and trying to do this and dissecting it and shutting the diagonal down and all those kind of things is not long area, long lesion.
Yeah.
very thick,
Pull
and the
back.
choice of the burr, which is a little bit oversized burr to break into that calcium nodule that you saw, is a very, very reasonable choice. It's
Good diagram.
all a thought process in all is pre-imaging deciding as to what
I think
modality to
there's
use.
a wire, I think.
David?
Okay. No, there is a looped wire.
Mm.
Yeah, you know, we're seeing some great live cases today. You know, challenging here. And I can't agree more. You know, Jazz, I did not do
Good.
a lot of pre-IVUS until I finally listened to
Go
what
advance.
you've been telling me for
Cannot, does not
years.
go.
I was kind
We
of
Go
had
down.
the
doing more
same problem,
post-IVUS,
even
to
I
be
think
honest with
this.
you. And you have convinced me.
Go. Yeah.
And I think
Good,
your
good,
comment
good.
that you said
Good.
multiple times,
There's
the
a
IVUS
looped.
doesn't go.
You do not allow
Still
them
get
to do
information.
live case.
Absolutely. Howard?
Okay, so you saw that we had a little challenge. There was a little bit of loop into with the wire, so needed to straighten out and push and pull. And I always say, if there is a difficulty, go with the dynaglide into the vessel. Don't. We're ready to do that, but you have to take that loop out. There was a slight loop which was very tough to see because so much calcium in this patient. You saw the mitral annular calcium, and so
No, also the issue could be the TAVR valve.
yeah.
Okay, so we had to be very cautious that though we were able to engage easily through that larger diamond of the Navitor valve, you just have to be cautious that if this back and forth movement will not do anything to this valve. Yes.
Okay, so we are ready now with a 1.75 bar. Go to our steps, which we say at the Y connector here, just a tap on the dynaglide. Good. Okay.
I like the idea of the atherectomy. I would probably use a 1.5 burrow with the idea once you get that. You can take shockwave down if you can follow up with it. That diagonal is super big. You know, traditional is probably not a good idea there with the calcium. If you lose it, you'd have a lot of trouble. So I think atherectomy is good. The only thing I do, I'd probably just start with a smaller burr where you got stuck down at the bifurcation, and the more proximal stuff you could treat with shockwave. And then, you know, obviously look at the diagonal after you've done with your initial atherectomy.
And I would say that absolutely I agree with your statement. Had we known that the IVUS catheter did not pass, we would have clearly. But since we have 1.75 open already, we went. But you are right. Absolutely, this is the case when you had a trouble passing IVUS catheter. If you cannot pass, you go with 1.25. We did 3/4 passing of the IVUS catheter, so it should be 1.5 bar, not 1.75. Absolutely correct statement.
I have a different. So if IVUS catheter did not pass, but at the level where the IVUS was,
Yep.
it was not because it was a tight lesion.
Yeah.
It was just, you know, the lumen was okay. So I think 175 bar was needed for the calcific nodule. And further down, there is no disease actually. Only at the level of the, it's what, we got a 3.0 at the level of the diagonal. I think we needed 1.75 bar.
Actually, I think it got stuck in that calcium that's distal where you were having problems. So now you got your burr down there. Yeah, that's perfect.
Yeah.
When do you burr the diad, Jeff?
Yeah.
I wouldn't do it now. I wouldn't do it because of the wire bias. I wouldn't go with those angles. I mean, if you can't cross it, you can't cross it. But you know, now we have modalities. You created your luminal gain proximally, and then I would probably use balloon technology here, and I use lithotripsy for the diagonal. After you've actually created more lumen and have more push from the
212 compliant balloon.
I mean, that's the safest, right? I mean,
it's the safest way to do. I mean, Anu, that's what you guys are thinking? Lithotripsy in the diagonal?
But also other question, that means this is actually a safest of the diagonal. Look at the angle. It's an acute angle. Safer than if you have an obtuse angle of the side branch. If you think that if you can want to do rotational atherectomy, this diagonal ostium is not a bad diagonal ostium where we think we can do rotational atherectomy. But right now what we'll do is we'll wire the LED quickly and then go to the side branch.
And that you can touch it back at lithotripsy in the nodule too and crack a little bit more. You may shave off the nodule. Sometimes because of wire bias, you may actually shave it off less. So your bigger bear most likely did the damage, but you can actually touch it with the shock wave if you were able to go into the diagonal.
But the diagonal shock wave will likely be 2.5.
Yeah.
We may need a larger one for the LED. I'm going to take the rotawire out. Okay. Oh,
Good.
if you need
Yeah,
it.
now we are going to wire the diagonal. We did what we did is we put our run in the LED. That is what we always do after rota is atherectomy is done. Although some people will try to do everything on the rota wire or so, but I say the problem is that if you got into perforation, those catheter even papyrus will be very tough to advance. So we always change it side by side. If there is a dissection, then you can use over the wire system so remain in the lumen. But in this particular case, I think we wanted to show, and the same thing what Jess said, our goal is that can we do this case without atherectomy, that diagonal. That's the whole case. That's what we want to teach. I mean, we have so many other cases, but always we have done impala and then complex cases, but I think this is a real practical issue. That can we in this day and age of our IVL, as I mentioned, the diagonal road atherectomy, that's where the trouble always occurs, if at all, perforation. So, and it should be like a last resort if nothing else works. So we are going to do first a balloon of the main vessel, or you want to go diagonal directly?
I think let's try diagonal.
What wires do you have there?
The fielder into the diagonal?
Yeah, fielder in the diagonal and a run through main vessel. In a way, it's good because they have two different colors, so it's very easy to keep going to the side branch and the main branch.
Right.
So you want us
You
to
guys,
212.
you guys are doing exactly what we do, actually. I love the fielder FC
Yeah.
because of the color.
Yeah.
And that's FC.
Yeah.
Because the radio opaque portion is not that long. The XTs have the radio. So this is fielder FC, and then you have a run through in your. So I think that's great, and you don't
that's the
confuse
thing.
the colors and stuff. So
Yeah.
that's great.
Let's go. This is the 212 now, compliant balloon.
Oh.
And going into the diagonal. This is the test. Oh, good. Now your 2.5 IVL should be ready, please.
No,
That's-
question is, did
it's
you
like-
want to IVAS the side branch?
It slid down beautifully, huh?
Yeah.
I guess you don't even need IVL.
No, we'll need the IVL. Such a more calcium. Although it opened up nicely, but I think we should do the ostium
Hold on,
IVL.
2.5, no, I think, you know what, get the IVAS catheter
No.
down. 2.5 or 2.75 IVL. Before that, I think it's good that we image. Also, we can see what we did to the nodule with the rotational atherectomy.
Yep.
I think 2.5 into the diagonal shock wave would probably be good. I think if you IVAS it, you probably see that it's a pretty calcified ostium of the diagonal.
Yep.
So even if you get a false sense of a balloon expansion,
Yeah.
it may not yield, and you may run into trouble. So.
Yep. Okay, we are doing it now. So now we are doing the IVAS, going through the our proximal LED, that nodule, and into the diagonal, large diagonal, and let's see what is happening there.
That's where I get messed up, that false sense of balloon dilatation. Think, oh, it fully expanded, and guess what? You're wrong.
No, good.
Okay, closed.
Okay, Kiski,
Yep.
start.
Could you show the IVAS on
Okay,
the
show the
screen?
diagonal, please, and now with the IVAS. Yeah, good.
Okay, start with work. Start from the lesion. It's in the diag, eccentric calcium. Now come to the main branch. 360.
How is the nodule doing?
Now coming. Yeah, shave the surface. I'll show
You
you.
shaved it?
Yep, I will show you.
This is our fast Avivo
Yep, I'll stop it.
of the Boston Scientific latest IVAS, which looks like a OCT.
Yep.
It can be 0.5, 1, 2, 4, or 8 millimeter per second.
Yeah, so this was the tightest birth, the calcium nodule. The MLD was 1.0, now 1.5. The surface is shaved.
Okay.
Now tell us the diagonal now. No, more important, this one we
Sure.
did for the diagonal. Tell us what's happening with the ostium of the diagonal.
So
we
now,
need to-
Go back.
okay, now this is at the osteo of the diag. And yeah, I see some like a revelation. And yeah, but
Actually,
still like a 270 calcium. Yeah, and vessel size is like 2.9 vessel, or a little smaller than that. Yeah, I mean
And
not that longitudinally long.
Yeah, go there.
calcium.
Stop there. Go
Yep.
inside a little bit.
Yep.
Inside. Yeah. Right there.
Yep.
Give the diameter there.
Sure. like a lumen,
Lumen.
like 1.7. And EEL to EEL here is like a 2.7.
Okay, give us 2.5.
Yep.
2.5 IVL. So if you
IV.
go back, actually not
2.5.
this kind. Here you can you do a cutting balloon also, but I think IVL probably will get a better expansion.
Yeah.
Yeah, your IVUS actually was very fast and it jumped around that angle. You actually have more calcium at the 270 degrees of calcium in the
To the
proximal
ostium.
diagonal. Yeah. And then you actually look at your nodule. Part of the nodule is completely gone. It's a black.
Yep.
That's why I think 175 was essential at that level.
Yes.
So now we are, the biggest advantage of the IVL is that you can leave the wire side by side. So we leave the LED wire and then we are going to just go. We are not doing too many pictures because we have done the IVUS already. And this patient with the 2 renal transplants, we want to just preserve as much as dye possible. So we going with the 2.5, the IVL in the diagonal now.
Okay.
Good.
Start.
Okay, we're ready to do, yep.
Go up.
Can we see
There
that?
you can see
Yeah,
the
yeah.
angle. Yeah.
Jazz was right. Look at that ostium. You see the. I'll have to pull back into the main vessel a little bit more. Okay, keep
Let's
going.
do one more here, yeah. And the question comes that do you need to do IVL in that calcific nodule?
No.
To me, I think it looks good.
I think you shaved off.
Yes,
You know,
yes.
Anu did a great job with the technique, and
Good.
you shaved off significant amount of the nodule. So, I mean, if I have something left, I know it's only 2.5. I touch that thing a little bit. The sonic wave will do something. I touch it on the way back. I wouldn't do another one in the proximal area. What do you guys think?
Good.
Yeah,
Good job on it.
yep.
Go there. Maybe we can go a little higher pressure on the 8 or 10 at that place.
Okay,
Not here.
do one more. Do
Okay, one more
I
here.
want
Yeah.
one more.
Yeah, at the level nodule, we go 10 atmosphere, although we are not supposed to go to high pressure.
Yeah, the problem with high pressure in here, now I know we are doing whatever it needs to be done, but high pressure results in significant rupture.
Yep.
And rupture of the shock wave is not a benign thing. We've actually had rupture where it was a bad rupture that actually the electrical thing fried the artery and we had a complication in the left main. So go high pressure results in rupture of the balloon. So you have to be very, very careful when you use it multiple times or when you do
Good.
are
One more.
going high
I'll
pressure.
go inside here a little bit. Okay.
Yep, absolutely. Go up. Yeah, same. The anytime rupture does cause a lot of diastasis in the wall. As such, we know that perforation is very rare with IVL and largely because of the low pressure. So that's why reports in the literature of perforation 0% to 0.2%, maximum 0.2, even in this calcific lesions and so.
Okay, good.
Yeah. You want to take one picture now?
Okay, we take one picture and then we have to decide stenting strategy. Go.
Good. What do you think now? Mini crush or just a?
You know what I would do?
Yeah.
You have such a beautiful result. I'm sort of tempted to do provisional here and make your procedure simple.
Yeah.
We think so also.
No, that's what we also decide. But before we do that, if we go to 2-stent strategy, we can go now with 2-stent strategy. But otherwise, I think we need to balloon it and have a good result and then stent the main vessel. Now, the main vessel, we did not dilate, right?
No, we are going to dilate now.
Yeah. 3.5?
Yeah. 3.0. No, 3.0 for there, 3.5 proximally.
Okay.
Yeah.
No,
So see, let me just complete, and we actually now coming with to the whether should be a provisional versus what. Go back to slides quickly, and we wanted to update all our audience there and everyone what Anu has developed. So many of the apps. Go to the slides.
Yeah, we don't see your slides.
Yeah, good.
Okay.
Yeah, so that was our plan, as we have multiple calcific lesions, rotation atherectomy with imaging guidance, and through the TAVR valve. And turns out to be was very easy for the TAVR valve. And you want to say about this? So this is actually the first bifurcate, was the first app which we had
Yeah.
For these cases. You see there.
That was just the illustration.
And
That
now
came out in 2017. Since then, you can see series of educational apps that we have created over the years. And today we just released another one called CAD Risk Score, which will be good for assessing all the risks for patients with heart failure. And then based on the CAD trial risk score paper that came out, to say what, when, especially when we are seeing the structural patients in the outpatient, to make the decision, and for the heart failure doctors also, so that they can get guidance, what will be the outcome if they get clip, or what will be the outcome if they just stay on medical therapy. So the risk score will give you a risk, and something that can, just like the symptom score, you can print it and attach it to their EMR.
So we have some demonstration of the bifurcate side by side and the provisional stenting. Good.
Provisional, okay,
Yeah.
we can. Ready? Done?
Yeah.
I don't think we have to take a picture, right? We have to go to the side branch, dilate it.
Okay.
2.5?
Yeah. 2.5 non-compliant now.
2.5.15
2.15
non-compliant.
non-compliant. So concept is that we have done IVL and we just want to make it a little more smoother with a 2.5 non-compliant balloon, and then put a stent across. So a provisional is the one which we are aiming for in this particular case. And particularly the TAVR issue.
I mean, no, that's a good strategy. The other option you could do is you could use an angioscope, or a scoring balloon here to avoid causing dissections, and so that you don't
Did you want IVUS?
do the stuff. So it's reasonable to do that. But I think when you did lithotripsy, you actually changed the compliance of the vessel and the deep calcium also. So that actually allows your balloon to expand uniformly and doesn't cause that much dissections either. So I think non-compliant balloon here is also very good.
So we see what happens.
Do this and then you can show.
You don't know, we know what lithotripsy did. Give me IVUS quickly.
Okay. So
I just want to IVUS to see what IVL did to the side branch, and then it's so simple. We just balloon it and stent across. So we can put a 3 of and then post dilate the proximal, right? Is that what you want?
Yeah.
You want a 48?
Yeah, 3 of 48.
What's the IVUS length, Kiski?
Because we didn't see it after the
Oh.
The giants.
Yeah, the initial IVUS did not go, so I think the length is going to be.
So what's the length of what you have?
I think 48 will be reasonable here. Yeah. Good.
We go IVUS.
Okay, good.
Whatever it takes to
Come closer.
Yeah. Okay. This is the IVUS of the diagonal now.
Yep.
To see what lithotripsy has done.
Okay, start feedback.
Yes.
It's coming. Yeah, it's all still there. Yeah, looks much bigger lumen. Come to the nodule part in the Flomax LED. And left main.
Yeah, I think you have a much better. IVUS did not jump, and you have a much better bifurcation that you're going to show us. There you go. Perfect.
So yeah, this is the osteo diag. Yeah, slightly better lumen. Some small fractures of the calcium. Yeah, but area-wise, it's like around 3. The osteo diag.
Didn't do much.
Yeah, you don't have any dissection. You have very good luminal gain. I think you guys are good there.
Yeah, some slight injury.
Any question from the panelists that would they compel? I mean, everybody feels strongly about two stent here. I think provisional seems to be a way to go, but if anyone feel that should do a two stents.
No, I think the main issue, the diag looks great. I think the main issue is just getting the length of the LAD such that you don't find yourself accidentally having to overlap at that diag origin. You know, whatever you choose should go across it, and then if you needed to put a second shorter stent more proximal, that's fine.
Yeah.
It also appears on your IVUS that you got a little bit of an impact with that smaller intravascular lithotripsy and the proximal ID too.
Yes.
The
need to
reason
go
why
a
you
little
do
further.
the IVUS bifurcation so much better
Down.
than what you did proximally is you did something to the, and you don't really have that much attenuation now because you modified the calcium and you cracked it with lithotripsy, not only superficial, but deep. And that's why your imaging
Yeah,
improved.
275,
Very,
right?
very good
That's okay.
illustration.
Okay, get us a 3 of 48. Open. Go back here.
Now let me ask you, people will leave just the wire or no wire or maybe a deflated balloon. What do you think?
I would actually,
Down.
in this case, you know, when you see calcium on the other thing, calcium from
Proximity.
definition criteria for bifurcations is your enemy. So I would protect something. So I usually do gel balloon in here, but you know what, in general, I think you have to leave your wire in place. The problem is you put a 48 millimeter stent and then you have calcium proximally. People have trapped wires in those scenarios. So I would be careful. I think your diagonal looked fine. You know, if I were just to avoid complication, I would just pull the wire.
What might help you, it's a 3.5 proximal vessel. So if he's going to put a 3.0, 48 in, maybe. But I would agree with you.
3.5, 15 high pressure.
What about just using
20.
Okay. I agree with that. Sometimes I think the stenting is not what jails the branch, is the post dilation.
Yeah.
So I think a lot of times if you can recross with another
Wanna give
wire
synergy?
after the 3.0 stent, it will improve the chances
should be
of patency.
Damn it.
Why?
Good point.
Should be Zant, right?
And,
Synergy
and
fine, that's
also
fine.
because your stent is 3.0 and proximally, and even if you deploy it and then pull the wire, because the
go
proximal
further.
area is not that opposed, your guide gets sucked in, your wire gets trapped, you deform the stent, and you run through problem.
I think you're
all
good
day.
now.
That's a
See that? Okay, take a picture, okay?
So your length looks good.
Yeah. You can go 2 millimeter in also, I'll leave it.
Look at where that septal
okay.
is. Right at that septal. I
Yeah.
think should be okay.
Good.
Okay, go up. You're 3.5 ready? Yeah.
Nicely expanding, very nicely.
Yeah, looks good. There's still a little indentation at the nodule.
Yeah.
The slight indentation at the nodule, but the distal, every phase is expanded pretty nice.
Okay.
Good. Just dial it. We don't take the picture. Now we take the wire out, right? Before. Yeah.
Now let's take a picture before, make sure the diag is okay before you take out the wire. Go.
Nice.
Always will look a little roughed up.
Yeah, I would consider rewiring into the diagonal at this point before your post dilation.
Okay.
I think it's flow also and his mark effect also with this wire jailed in there. I would take a post-dill balloon now. Don't pull the wire. Use that trapped wire to deliver your balloon because it's a mismatch of the thing. And then after it's delivered, then you try to take the wire out. And also it makes it less traumatic because if you then won't suck the guide, you'll suck the guide over the balloon and it's less traumatic.
Good. Okay, we are dilating proximal with the 3.5. I think the wire proximal wire has come out, right? Diagonal wire?
No. It's okay.
It's still there, okay. You want to leave it there for the time being, right?
No, he's saying deliver it, then take it out.
Yeah.
So right around there.
Okay.
Okay. So now I'll take out the diag wire. Wait. Okay.
See that? Yeah.
Okay, pull back.
So
Good.
when your 7 French guide got sucked in like that, it got sucked in over the balloon. So you are safer. So that was a good illustration there.
16.
You're good?
Yep.
Okay, let's see now how DAG is behaving after this. Okay, go up here. Proximal edge, yeah. Now you got 20 there. 20, yeah. IVUS is ready. Final.
And we got 3-4 minutes. We'll be on time.
Yeah, I think you guys are doing great.
This case really illustrates the nature of calcific CAD. Even though it may look focal or nodular, when you do an IVUS, you'll realize that the calcification is almost 30 millimeters long. And this is a fantastic illustration of that, especially in all these dialysis patients.
IVUS.
So
Minimal dye, yes.
I was seeing the main branch now.
Main branch, yeah. Main branch, yeah. And see, and then we take the last picture.
Yeah, EKG anyway was a bundle branch. We don't see any changes because that's one important thing also in decision making. TIMI flow, any kind of chest pain, EKG changes to rewire or take care of the side branch. Okay, we are ready for the IVUS again.
Yeah, it
At
crossed.
the distal
Great.
edge.
Okay, I check the image.
Good.
It's a native. Okay, start back. It's coming.
Yes.
One more part. Yeah, edge of the stent. Nice. No edge dissection. Very expanded. Onto proximal. Nicely expanded. Yeah, aerosol.
That's great.
Yeah, looks great. No dissection. No malposition.
Proximal edge is okay.
Yeah, looks good. Like
Take the wire
almost
back.
level of the D1, but well expanded, well opposed. And I'll show you the tightest part. Like looks, we lost the nodule. I mean the alarm here.
Nodule is bye-bye.
Yeah, area is like a 10.
10.
Yeah.
Yeah, no, the area looks good. There is little malopposition on one side, but those in calcium, you cannot make it perfect. So this is an illustration that you don't take a balloon and try
Ready?
to make it look perfect, because that's when you do rupture. So it looks very nice.
Yeah, perfect.
DAG looks roughed up.
Hmm?
DAG looks roughed
That
up.
roughed up, but I think we leave it. Once we plan, because by all the criteria, lumen is less than 70%, the TIMI 3 flow, there is no chest pain, although patient may be a little under sedation. There is no EKG changes, although patient has a left bundle.
So it looks good. Before we go,
Yeah.
I think it's important. Tell us how you're gonna remove the guide catheter through the cage of the valve, because
Yeah, we're going
as
to
you know, there are
demonstrate that.
instances where you can get
Yep.
trapped.
Yep, that's right.
I think your diagonal looks great.
Reasonable, yeah.
Yes.
It's an angioplasty
Good,
result.
good angioplasty result. Agree.
And
Absolutely.
and within less than a month, we'll be doing a drug-coated balloon before coming out in this case, which agent will be available by end of this month clinically, and although very expensive, but will be available for our clinical use.
All right.
Yeah, so if you see here,
Yes.
But look at that taking out. Yes, as you said that many times those can take the tower valves with them, and that has been reported actually, particularly in the acute MI setting, when a lot of
Yeah, if the
anxiety.
guide- Yeah, if the guide hooks around the cage, then you have big problems. So that's
Okay.
it's very important to be careful.
in our app
No.
called TAVR Cath Aid, we actually have animation of how to engage and how to take it out. That in this situation where you can disengage from the left main, and then you can use your J-wire, J-wire. So get your J-wire in through the cage first, and then get the guide out slowly. Like you all were mentioning,
Yeah,
is
and
that we dislodge of the tower does not happen.
Yeah, and that's what I was getting at. So thank you very much for making that point, because at the end of a beautiful case, you could mess it up just by taking the guide out. So
Yeah,
great job.
Oh, that was great. Samin,
And-
Anu, as
yes.
always, you guys did amazing job. Thank you, the whole
Thank
team.
you, thank you.
You guys look amazing in the arch hats there. Thank you very much. Thank you.
Yeah.
Okay.